Welcome and standing by. At this time, all participants will be on a listen-only mode until question and answer portion. During time, you may press star followed by the number 1 on your phone and record your name clearly if you would like to ask a question. Today's call is being recorded, and if you have any objections, you may disconnect at this point. Now, may I introduce your first speaker for today, Mindy Cook. Please go ahead.
I Get With the Guidelines Heart Failure Midwest Affiliate webinar today focused on best practices for hydralazine nitrate and ICD, CRTD, and P therapy. Okay, if I can get my slides to advance. Okay. So as I'm familiar with our programs, we have a suite of quality improvement modules that hospitals adhere to the evidence-based clinical practice guidelines for cardiac and stroke patients. We have several modules, like I mentioned. Those are listed for you here if you're not familiar. Today we're talking about our Get With the Guidelines heart failure module, but we also have programs for stroke resuscitation, atrial fibrillation, coronary artery disease. We have partnered advancing certification and accreditation programs as well. In our Get With the Guidelines modules, we have over 2,500 hospitals participating, with nearly a million records entered across all the modules. Each of the U.S. population is covered by one or more of our quality improvement programs. In our failure module specifically, we have just over 1,200 hospitals participating across the country and about 1.8 million records entered. We've been on the Heart Failure Initiative since 2005, so it is one of our legacy programs. Today we'll talk about 3 that are quality measures within our heart failure suite. We're going to describe the scientific logic and rationale, coding instructions, and inclusion/exclusion criteria for the hydralazine nitrate, ID, and CADP therapies. We will demonstrate documentation tips and best practices on these 3 measures, and then we have our guest speaker from the University of Kansas, who is a heart failure coordinator, and will describe how they've achieved success in these measures. And then we'll end with a view of our key standards and eligibility requirements for the Advanced Heart Failure Certification and Comprehensive Cardiac Certification programs we have partnered with the Joint Commission. To take a quick glance at our agenda for today, I will start things off, and then we'll things over to Sarah Sanders, who is our guest speaker today from Kansas, to relay our heart failure best practice in their hospital system. And then we'll go today with Kaylee Saha from Kansas, who's going to review the certification partnered program. I'll start things off here with a review of the measures. Like I mentioned, these 3 measures are part of our quality measures. For those who work in our Get With the Guidelines program and have achieved awards, our achievement measures are the core awards, and then our quality measures are the plus component of the awards that those of you would be eligible for. So these met at 75% adherence, then you can choose from a group of these to focus your program on. When we hydralazine nitrate discharge measure, this is a class 1 recommendation, combination of hydralazine and isosorbide dinitrate. It is recommended to reduce morbidity and mortality for patients in the African population with a heart class of 3 or 4 and ejection fraction. It is a 2-in combination of those 2 medications to reduce morbidity and mortality in patients with prior symptomatic cuff RAS who cannot have an ACE/ARB because of a drug intolerance, hypertension, renal inefficiency, or if they're contraindicated. So both patients, whether they are on optimal therapy or are ineligible for the adjunctive medications, nitrate discharge is recommended. If we look at inclusion criteria for this measure, these are patients with a principal diagnosis of heart failure. They must have an ejection fraction of less than 40%, and primary cardiac diagnosis of heart failure with no C or with CAD, have a qualitative ejection fraction. You can use a qualitative description of severe dysfunction to include these patients in the denominator. Those include numerators, so passing the measure are those who HYDRALAZINE and isosorbide dinitrate at discharge. If we look at a snapshot from the patient management tool, it shows how you document the hydralazine within the PMT. There are 3 contraindication options there: a medical reason, a patient reason, and a system reason. Reasons would be those like they're allergic to organic nitrates. A patient might be something like they didn't decline for a social or religious reason, and a system reason would be something like coverage or payer limitations, or a reason attributed to the healthcare system that that patient won't be able to receive that therapy. If we look at solutions for this measure, there are many. It is less than 18 years of age, is transferred for either acute care hospital or a designated cancer treatment facility. If they left against medical advice or were discharged on hospice or expired during their series, they'd be excluded from this measure. If we look at this measure over the last 5 years with a Midwest affiliate, this is our state benchmark here in the Midwest, you see that our adherence hasn't significantly changed over the last 5 years, and that's why I think this was an important one for us to focus on. See, we're hanging just around the 30th percentile of adherence quite consistently for the last 5 years. Talk about today is our CRTD or CRTP placed or prescribed at discharge. So this is chronic synchronization therapy and with a defibrillator or a pacemaker, for those of you who aren't as familiar with the acronym for that. But T is indicated for patients who have an elevated ejection fraction of less than 35% or in sinus rhythm with a left bundle branch block and a QRS duration of greater than 150 milliseconds. You have a New York Heart question of 2 or 3 or ambulatory class 4. This level recommendation for therapy in this population. There are other caveats and recommendations. So in the 2A group, CRT useful for patients with an EF of less than 35% with the other features and less bundle branch pattern to their QRS complex, but it is also more than 150 milliseconds. So that would be the main change with this recommendation. There is still a level of evidence A. The third is that CD can be useful for patients with sinus rhythm, left bundle branch block with a lesser width of 120 to 149 seconds, and a heart class of 2, 3, or ambulatory 4. Is CRP can be useful for patients with AF and less than 35% on guideline-directed medical therapy. They regular pacing or meet CRTD or P-TIRIA. So if they be node ablation or pharmacological rate control and they're not able to maintain their own sinus rhythm, requiring percent pacing, this is a level of evidence B. For the in the last grouping here, and this class 2A recommendation on guideline-directed medical therapy, that's of less than 35% and undergoing new replacement device with an anticipated requirement of greater than 40% ventricular pacing. It is a level of evidence B recommendation. Here's our 2B recommendation, and these patients who could be considered who have an EF of less than 35%, sign in a non-left bundle branch block that is rated 120 to 149 milliseconds, and classification of 3 to 4 guideline-directed medical therapy. The exclusion criteria for this grouping, you can see the recommendations entered here into the inclusion criteria. So the features of ejection fraction less than 35%, a QRS complex, the left bundle branch block, or without. In the exclusion to our other measure we just reviewed, if these patients are transferred to another acute care facility, they're not eligible if they are expired or leave on against medical advice or on hospice therapies, they also would not be included in this measure. If they've been documented in the record for not prescribing or placing that therapy by a provider, they're also excluded. If they have new heart failure, they would not need recommendations here because they're not on guideline-directed medical therapy. And you can see those illustrated a little more clearly and exactly which elements are included on the right. Wheeling instructions and how these patients are entered into the PMT here. You can see it asks you if they are placed, the CRTD P or P are placed or prescribed, and then what those reasons might be. Several reasons for not CRTD, like that patient is not on optimal medical therapy, their heart class is 3 or not or 4. If they've been in the past 3 days or a recent revascularization or a new onset, the best complex is less than 120 milliseconds. There also is an exclusion, and then there are other reasons there, like patient reasons and system reasons, which are reviewed and might be patient not to have that therapy or the services are not available at the center where this patient is. If we look at our compliance to this measure over the last 5 years, we are doing considerably better than the isoscyl nitrate measure. We hit 57% here in 2013, and we are up to 66.8, so definitely some improvement there, but that still leaves a number of patients who would be eligible for this therapy and could benefit, who may or may not be treated appropriately in this group. All right, our here is our ICD counseling, placed or prescribed at discharge. This is a class 1 recommendation for patients of primary prevention of sudden cardiac arrest to reduce total mortality in selected patients with non-ischemic or ischemic heart disease at least 40 days post-MI with an EF of less than 35% and heart class level of 2 or 3, chronic T who have reasonable expectation of a mean survival for more than 1 year. Recommended primary prevention lesser VEF population there too is as a level B recommendation group to prevent cardiac death placed in ICD is reasonable in patients with asymptomatic ischemic myopathy for at 40 days post-MI who have an EF of less than 30% and are appropriate medical therapy and have no expectation of survival of more than 1 year. And it is a Class 2B recommendation as usefulness of benefit to prolong meaningful survival in patients with a high risk of sudden is predicted by frequent hospitalizations, advanced frailty, or comorbidity such as cystic malignancy or severe renal dysfunction as a level of evidence B. We look at the exclusion criteria here for our measure. These patients are those with a principal diagnosis of heart failure and documented ejection fraction of less than 35%. We are excluding 18 years of age, transferred to another acute care facility, or discharged on hospice therapy or lost medical advice. If then for not prescribing ICD counseling that is documented in the record, they will be excluded. The patient has a new onset heart failure. We look at the questions in the PM for this measure. You can see here there are several questions related to this. Was counseling provided? If not, what reason for that counseling not being provided might be if a patient already has a device in place or multiple or significant comorbidities that would preclude them. If they have that limited life expectancy, not to exceed to be over a year, that is a reason that is acceptable. If they don't have an ejection fraction less than that 35%, another one that would be acceptable. The medical reasons would be those we covered, and similar to the CRT therapies. They've had an in the past 40 days with a recent regularization or recent onset heart failure. And of course, there are patient and system reasons as well. You can see our adherence here for the last 5 years in the Midwest affiliate as well. We improved the adherence to this measure, still just at that 62 percentile, but at 47% 5 years ago. So we've made gains, but still some room to go there to improve of these patients and offering this therapy to those who meet criteria. We're going to turn things over to Sarah Sanders from here, and she's going to talk about the program in Kansas. Let me just make her enter. Sarah, are you load your slides? So Sarah's program coordinator at the University of Kansas for the past 5 years. Her role encompasses both the outpatient and inpatient care, including the development of the outpatient heart failure infusion clinic, heart failure services, and collaboration with the interdisciplinary teams, including paramedicine, social work, case management, nutrition, and pharmacy, to name a few. So she's integral to building collaborative relationships not only within the health system, but with community partners and home health palliative services. So over to Sarah. Thank you for joining us today.
Thank you, guys. Okay. So I just want to thank me and Kaylee for the opportunity to speak with you all today. Really, this station really started out as, the question is, what do you do? I get that all the time. What does a heart failure program coordinator do? And I well, it kind of sort of depends on the day. In terms of primary roles and responsibilities, been this for a while and recognize that not all systems are able to implement program goals. However, though, if you're able to, it can be a great benefit for your health system and for implementing improvement things related to our evidence-based guidelines. So one of the, I just want to provide a little general overview of what I do. The base of that is data, data, and data. And that's one of the reasons why we're here today, talking about Get With Guidelines. That is one of our primary registers that we utilize in terms of evaluating where we are with our metrics and performances. We also use benchmarking data, and I think this is very important for anybody that is involved in a program, in any kind of disease management. But it's really important to understand where you stand with others similar in terms of your system. So for, and everybody to use may use different organizations to do this, but for us, we utilize Vizient, and we are basically put in a cohort of other academic institutions, and so it's great to be able to see where we lie with regards to our performance. It also provides an opportunity to collaborate with those other institutions so that we can, share best practices. My job is always looking at our ambulatory data and trends as well as inpatient. In the development of standardization of care for our heart failure patients. We were very fortunate, about 3 years ago, we had a basically kind of statewide workshop for 2 days in which we pulled together an interdisciplinary team that had a significant amount of depth and looked at the care that we're delivering for heart failure here within our health system. Using standardization, helps you to identify the barriers and gaps that are related to the delivery of care for your patients. It helps to develop relationships with your interdisciplinary colleagues across the continuum. No one can successfully do heart failure without those relationships with partners, primary care, those partners that are with their health systems, but also those partners that are providing care for your patients in the community. Again, another big piece of my role is education within our health system and community. But I do get to do a lot of fun stuff. Education is one of my most favorite things to do. Research. If any of you are interested in partnering and doing some nursing research, we are developing a couple different protocols looking at some heart failure the care inpatient and looking at utilization of applications, app-based tools for patients. Looking at how we can create different models of care for, to improve access for heart failure, whether that's looking at how you can utilize your advanced practice providers, your nursing staff, utilizing resources that are out in the community, such as paramedic programs and community health workers. Collection. One of my favorite things to do is to work with a variety of team members that are involved in all sorts of different facets of care. And I tell you that this only probably because I am still a graduate student, and this kind of has fallen in line with some of the schoolwork that I've done. But I have become, I have really realized that from a leader's perspective, to really understand your system, you have to be able to have some of those tools so that you can identify where your needs lie for your patients. And then it's looking at development of innovative models of care. Oftentimes, usually can come from partnering with other colleagues, throughout the state and throughout the region. Again, looking at technology, there's the fire. It's kind of a wide open space right now. I'm not sure how many of you all are utilizing CardioMEMS. There's new technology that will be coming out, that is available with some implantable devices. And it's also looking at opportunities for wearable data as well. So today I will be focusing on discussing how we have improved, evidence-based, you guys, EVP. And for some reason, evidence-based practice, it should always be EVP. I changed all of them to that one, so I apologize. But today we're looking at focusing on HEF-REF. All of you pretty much should do with anyway. The guidelines really are only directed towards these patients. So many of our implementations and things that we've done here are specific to that demographic of patients. Emphasize enough the importance of education. And I say this because depending on where you are, patients can be delivered by a number of different providers. That's your primary care hospitalist services, cardiology, nephrology, and some of those other services. Heart failure patients lie anywhere within a hospital. So I know I don't really have a way to do this easily, but I just kind of want to get you guys thinking today. I'm going to throw out a couple trivia questions. False. Concoction of a beta blocker in conjunction with an ACE inhibitor will increase the risk of mortality for patients with a heart failure. We answered that before we even got through the question, but that is false. So, to see if you guys know what that actual percentage of reduction in death is when you use a beta blocker with an ACE and ARB. Is it A, 20%, B, 57%, B, 77%? 1%. I think that it's really important to understand about heart failure. Evidence-based medications and management therapies have a cumulative effect for patients. There's incremental effect. So as you build on each piece of guidelines, you improve patients' outcomes and reduce the risk of mortality. It's one of my most favorite slides. That was provided by Dr. Yancey, and the team works on developing the guidelines. Looking at patients who are only on an ACE or an ARB, you reduce the risk of death within 24 months by about 38%. With a beta blocker, that improves by 77%. And then add your CRT and ICD therapies, and you can reduce the risk of mortality within a 2 period by 90%. I think this is just fascinating to see this. I'm a very cool person. But again, this is one of those key pieces in terms of educating your providers and your clinical staff, your nurses, to understand that implementing guideline-based management therapies goes beyond just a checklist. And making sure that we're meeting guidelines because we want to fall in line and make sure we're answering the right questions. We do this because of the great benefits and the improved outcomes that we have that we're able to share with patients. So implementing evidence-based practice here at KU. We're a rather large hospital. We've grown substantially, especially with our heart failure program within just the last 5 years. Again, it's coming down to education and making sure that we are identifying areas for care variation. Here at KU, the majority of heart failure care is often delivered by hospitalists and other attending services, such as family medicine, teaching med service. Part of my doctoral project has been looking at improving prescribed practices for primary care. And if you look to the literature, there is a lot of evidence out there that identifies that, the number of patients who are being diagnosed with heart failure and developing heart failure is moving at such a rapid rate that the ability of cardiologists to keep up with that volume is just not going to be manageable. So as we move forward with our aging baby boomer population, the need for these other primary attending providers to deliver care is going to be very important. So it's very critical that we ensure that we have access to knowledge for those providers. Using knowledge can be limited when you have patients who are not necessarily on a cardiac-focused unit. Here at the University of Kansas Hospital, we actually have a art center in which we have dedicated cardiac-focused units. However, 25% of our total heart failure volume often falls off into other non-cardiac units. So it's ensuring that your nurses are knowledgeable. Lack of knowledge overall, just related to the guidelines, is somewhat a barrier. And you step outside of cardiology, there's oftentimes a lack of comfort when it comes to implementing some of these therapies, as well as a lack of access to adequate tools and resources. And I'm not sure what the practice breakdown is with people participating in this call today, but as you step away from academic institutions and urban areas and start to move into more rural areas, you see that knowledge gap becomes a little bit greater. So here at KU, we've implemented standardized clinical education systems. So nursing gets standardized annual education regarding heart failure, and that is across the entire system. So all inpatient acute care bedside nurses receive standardized heart failure education on an annual basis. Our provider education has been standardized, and we are increasing access to opportunities for our attending physicians as well as our residents and fellows. All of our providers are responsible for completing annual education, and we see compliance to that. That actually is also a requirement for comprehensive cardiac certification. And then again, it's just trying to utilize a variety of areas and arenas for education. So we've developed online learning modules that are self-paced. We host an annual cardiac nursing symposium. We'll do grand round presentations several times throughout the year for our physician and nursing partners. We do nursing in services, and then also provide access to community-based programming. So trying to, as the awesome opportunity to do education such as this, but also to go out and do education with home health, with our home health partners, hospice agencies, the local area hospital and other health systems. And again, it's offering the ability to have access to conferences and other educational opportunities. So today, we're going to focus on hydralazine and devices. And I will tell you that here at KU, while it's mostly all anecdotal, a lot of the barriers to this documentation is really the fact that it's very specific. Hydralazine is indicated for a very specific population. I think there's some lack of knowledge regarding the use and the indication for hydralazine for patients. And sometimes, there's a lot of provider discomfort with initiating therapy, especially if you're a patient, or if you're a provider who is caring for someone in the hospital. On average, heart failure patients carry 5 to 6 comorbidities. If you are, a GP or an internal medicine physician who is trying to manage, 6 comorbidities, heart failure, a lot of times the perception could be, I understand that it's a component of the guidelines, but I'm not quite so sure if it's appropriate to initiate at this point. So a lot of times that may get left to be guided in an ambulatory or outpatient setting with cardiology. But again, that is all anecdotal and just based off of that I've seen and experienced. We have worked really hard to standardize our core measure documentation. We developed some smart phrases. We use EPIC here at KU. However, I have lots of colleagues who use Cerner and other tools or EMRs, and I know the majority of EMRs have the ability to provide some of that customization. And EPIC has a lot of tools to help with as well. Another piece of it is really ensuring that, our interdisciplinary team help provide the oversight and feedback regarding the deficiencies to documentation. I was one of the who had a great opportunity to actually utilize the documentation that I helped implement as a nurse practitioner student. And it's very interesting to have to kind of work through some of those intricacies of the documentation related to the patient care. And I had a kind of reality, I guess, a reality moment where you recognize, what you think easy and makes sense as a program coordinator doesn't necessarily always translate well into practice. So again, it's important to have that interdisciplinary team so that as you can develop those tools, you can get feedback as to how well something will easily implemented and how easy is it to use. I think one of the, one of the issues or deficiencies too is the fact that, heart failure is one disease process that has a lot of requirements and needs, but again, it's only one of many. So, we have physicians and advanced practice providers who are trying to provide care to a rather large demographic. For one, what may seem like a small percentage of their patient population can be somewhat overwhelming for providers. And there's, sometimes barriers within EMRs and how we use those. So it's important to be cognizant of what, of the workload and what this will train to for when it comes to implementing into practice. So things that we did to help improve this is we tried to significantly reduce the number of order sets. We basically have we have a discharge order set that is utilized for the majority of patients here. Recognizing there are some specialty program services that require some different discharge requirements, but overall, all order sets here at the University of Kansas include identification of patient quality measures. So you are going through and reconciling discharge, are asked to identify, was this patient treated for AFib, flutter? Did they have an acute MI? Are being treated for heart failure, cardiomyopathy, PCI, stroke, vascular interventions? And this was built to help kind of make it a little bit simpler for providers so that you don't necessarily have to think through what all the requirements are for those. If you just are able to identify those disease processes by clicking on the corresponding tab, it will provide you with the questions that are specific and related to those quality measures. So if you click on heart failure, it provides citation for beta blocker, ACE, ARB, ARNI, aldosterone antagonists and devices, and gives the provider an opportunity to address those therapies. And the tool that we have implemented is a kind of a smart text that is available and utilized by providers. So your physicians and your APPs, this can be utilized in any of the documentation, whether it's a progress note, H&P, discharge summary. And again, it provides an opportunity for our care teams to identify those things that are important for heart failure, identifying what type of heart failure they have, their EF, whether or not they have a device present or not, regulation, and so on. The other important thing is that everything that we've built is reportable. So when we're trying to implement these pieces, it is always very important to be cognizant of of how, of built in a manner that makes it easy for you to pull your data. Because again, in terms of tracking your performance, you want to be able to pull this out in abstract and figure out, if you're not succeeding very well with a certain measure, what is, what potential barriers for that. So this has been extremely helpful for us to ensure that we're addressing all of that guideline-based management therapies that are recommended for patients. Indications for device therapy. This sometimes can be, I think, a little bit tricky, and there's implications for this not only on the inpatient side of things, but also ambulatory. And having the opportunity to do some clinical rotations at a variety of health systems has been somewhat eye-opening when you start to look at some of the barriers to heart failure care. A lot of times device therapy, if a patient is hospitalized and is being cared for by a primary care or hospitalist service, they will refer to cardiology or sometimes to the heart failure specialist to make that determination. So there may not even be a discussion, in the hospital, depending on access to these resources. This requires collaboration with your electrophysiology team to set appropriate plans of care and making sure that you have the right type of follow-up management. Many arrhythmias will predispose patients to develop heart failure. AFib probably being one of the most common ones. Long-standing uncontrolled AFib can easily transition and lead to heart failure for patients. It's important to have those relationships with your EP providers and electrophysiology folks so that you can help to come up with processes to identify those patients, because a lot of times I think they sometimes end up hiding under the surface in EP. And they can be for a variety of reasons, but EP is there to address electrical issues. So if EP can fix a rhythm issue, they're going to try their hardest to do so. But recognizing those patients who are at risk and making sure they have adequate follow for that. About the work that we've done in standardizing our documentation, I really show you kind of where we started out. So in 2014, you can see we had we were not doing very well out of things, specifically hydralazine nitrate at discharge. We were only getting at about 26.4% of patients who really fit the appropriate criteria. We're working very hard to help improve documentation and awareness of the importance of making sure that patient is addressed and appropriately prescribed. And again, you can see here with our CRTD device placement and counseling, we were lacking in that as well. After our implementation of the standard documentation, we were able to significantly increase our compliance with documentation. And currently, here's kind of where we stand. Now, we have a little asterisk by this because this is our preliminary fourth quarter data, but we're all doing pretty well. Our hydralazine nitrate tends to ebb and flow a little bit, where we were at, I think we were above 90% in third quarter, but dropped a little bit down to 85% in our quarter. And a lot of times, I'll be honest, it's a matter of the medication not being prescribed. It's a matter that it isn't appropriate. So it's just that there needs to be documentation as to why it wasn't appropriate to start or to put the patient on that. I think that our teams do a relatively good job due to the constant education and reminders. Done a really good job of becoming very knowledgeable as to these lines, and I've done well. Again, it's trying to figure out how to address your documentation piece of that. And again, an interdisciplinary team is essential. It's a must-have in order to implement any kind of process improvement, and especially when you're trying to implement evidence-based guidelines. And it really requires the development of relationships. You be able to partner and to maintain those relationships. And you have to be able to mechanism to provide feedback regarding compliance and performance with specific guidelines. It's one thing to implement tools, but another thing to be able to consistently give feedback and to make sure you're partnering with those providers to understand if there are any barriers and reasons for why maybe we may be missing the mark with some of that compliance. As a part of our, taking the work we've done with Get With The Guidelines and moving towards certification, we made a decision 3, maybe actually more like 4 years ago, to be working on seeking the TJC Comprehensive Cardiac Certification. And I kind of want to speak to this. I'm not sure if everybody here is using Get With The Guidelines or participates in certifications for heart failure, but I could have been able to do my job without either of these tools. Having data at your fingertips really helps you to develop opportunities to identify where you need to step things up. Where is it that you've got gaps in your patient care, and where is it that you really need to focus your intervention? And so, it's really been helpful in developing our program and prioritizing program development. Resources, allocating resources, whether that be some staff, whether that's tools or access to certain analogies. It's been very helpful to give me the ability to push to allocate resources for our program so that we can improve care across the continuum. It helps you develop and build your interdisciplinary team, because it ultimately is a requirement of advanced certification, and helps bring people to the table who can provide valuable insights and really help to identify what the needs are. So here, but in conclusion, process improvements here have been helpful in reducing care variation for heart failure. We've done a lot of work to standardize our provider education and implementation templates. And the other pieces of that was the development of an interdisciplinary heart failure quality committee. And this team is one of my most favorite meetings to host. I host lots of meetings, and this is probably my most favorite because it our team members together to identify our compliance and adherence and look at our performance with these metrics and work together to really try to troubleshoot some of the, one of the causes and contributing factors to some of our performance issues. It's always interesting to get other perspectives because a lot of times if you've been doing heart failure for a long time, as I have for the last 10, 15 years, your lens get very focused and very narrow. So being able to step out and see the implications of higher care in other areas has been very helpful. And these team members really help provide that. And again, it's an opportunity. We are continually monitoring our performance measures. I work to identify some, we start having some early trends or gaps that start developing, evaluating those and trying to identify what the relational components to that and work on developing some process improvement. So that being said, I want to thank Kaylee because maybe you've had the opportunity to meet Kaylee, but she has come on board with the American Heart Association and has just taken off running and doing amazing work, especially with our heart failure community. And I just want to thank her for hard work she's done this year, and I look forward to the programs and things that she is already working on for 2019. And if you guys have any questions, please don't hesitate to give me a call. I am always happy to share our tools and resources and things that we've utilized here that have been helpful in improving our outcomes with our Get With The Guidelines. So thank you.
Thank you so much, Grace. Just a second here, just to switch over slides to Kaylee's presentation.
Thank you, Sarah. That was wonderful. Can my screen?
Not see Keely. Okay, so
you. I'm going to talk for a moment about a couple of our new partnerships with the Joint Commission on certifications. The first was Advanced Heart Failure Certification. It is offered by the Joint Commission in collaboration with the American Heart Association. We will assist organizations in helping patients manage chronic disease, reduce unwanted variations in care, and improve the patient experience, improve efficiency and outcomes at a potential lower cost, position your service line to effectively face new challenges, survey approach that combines unique surveys what AHA has to offer, receive recognition of your quality program, promote the culture of excellence to boost retention and recruitment of talent. And of January 1st, 2019, all AHF certified organizations will be required to participate in the AHA Get With the Guidelines Heart Failure Registry. For advanced heart failure certification are that you meet the core standards in the disease-specific care manual as well as the advanced disease-specific care requirements for heart failure. The organization chooses and implements heart failure clinical practice guidelines. You meet the 6 state performance measures for inpatient programs and an additional 7 optional measures for outpatient programs. For certification are to review the standards, certification participation requirements, and performance measures for which you will be expected to comply, get your questions answered by contacting us, conduct assessment, new policies and procedures you'll need into place, and submit your application. So here are performance measures, the mandatory core measure set, discharge and evaluation of systolic function, and ACE or ARB for ventricular systolic dysfunction. The main as of January 1st, 2014 measures for inpatients, you'll see blocker therapy, LVSD at discharge, post-discharge appointment for heart failure patients, physician record transmitted, addition of advanced directives, directive executed, and post-discharge evaluation for heart failure patients. The options for outpatients, hospital outpatient beta blocker therapy, prescribed VSD, hospital outpatient ACE or prescribed for LVSD, hospital outpatient aldosterone receptor antagonist prescribed for LVSD, hospital outpatient New York Heart Association classification assessment, outpatient activity recommendations, of advanced directives, care plan, and hospital outpatient advanced directive executed. The Comprehensive Cardiac Center certification. In collaboration with the AHA, will be offering a combined Comprehensive Cardiac Center certification as of January 1st, 2019, which merged the Joint Commission's Comprehensive Cardiac Center certification and the AHA's Cardiovascular Center of Excellence accreditation. All to the Comprehensive Cardiac Center program reflect a collaborative review of existing requirements alongside the latest standards of practice and professional literature. Scope of the Comprehensive Cardiac Center certification, the curricular risk factor identification, cardiac disease prevention, management, triage, and risk stratification of emergent cardiovascular conditions, providing direct care or stabilizing and transferring patients who require care beyond the scope of services provided, providing consultation, referral, and transfer arrangements, and for discharge, follow-up, and transition of care. Management of ischemic heart disease through medical intervention and surgical care, including acute coronary syndrome treatment, of cardiac valve disease, replacement or repair, of dysrhythmias, e-services, and outpatient device clinics, management of cardiac arrest, heart failure management, including patient services and cardiac rehab, either on-site or by referral. So certification, this is provided by the Joint Commission. You will be able to meet your associate director by emailing certification@jointcommission.org. They're different depending on your area. Steps for application: review standards in EDIT and analyze gaps, identify clinical practice guidelines, identify performance measures, complete the performance improvement plan. On application, and you can complete that through Connect Portal, and you'll have your on-site review. Typically 4 to 6 months after your application is completed, they'll give you a 30-day advance notice, and you'll upload the most recent 4 months of data for performance measures prior to the visit, and you'll have reviewers for 2 days. Just a bit of the new Comprehensive Cardiac Center certification. You'll have integration with staff, patients, and payers. It will promote achievement through a systematic approach to clinical care, promotes a culture of excellence across the organization, reduces variability and improves the quality of patient care, and creates a loyal and cohesive clinical team. It's an objective assessment of clinical excellence. And on this, we're learning along with you, and you're welcome to reach out to your Midwest affiliate Quality and Systems Improvement Director for Get With the Guidelines Heart Failure. I have a step here for each state. And I believe we'll end this with questions from that.
Thank you. We will now begin the question and answer session. For the participants on the phone, if you would like to ask a question, you may press star followed by the number 1 on your phone and record your name at the prompt. Your name is required to introduce your question. And cancel your request, you may press star 2. Once again, to ask a question, please press star followed by the number 1. One moment to see if we have questions. We show you at this time. Once again, to ask a question, please press star followed by the number 1. One moment, please. We questions over the phone at this time, but there is a question through the WebEx chat if you would like to check it.
In the chat.
To me, by a participant privately, and participant is Jack Marinak. The question is, Sarah, thank you for the information. How much of your education for inpatient nurses is skills-based versus knowledge-based?
That's such a hard question. For nurses who are in our heart center and primary cardiac units, a lot of skills-based education and training that they undergo that are specific to heart failure. We have patients who are transplant, we have VADs, and those types of things here. So there's a lot of education that is more in depth and more specific to some skill and knowledge for those nurses. When you get into kind of the general population in units, a lot of that is just kind of knowledge-based education for those staff. We've had some discussions about we want to expect to doing some skill-based education, but you having to be careful to balance the knowledge and the expectations and really maintain their science, but maintain their competency can be awfully difficult because a lot of times these don't have a significant number of heart failure patients on a continual basis. So for the majority of nurses that are falling kind of outside of our cardiac realm, it's primarily knowledge-based education, whereas those who are cardiac-specific focus, there's education is more detailed, has greater depth, and does expand upon some of those skills, like hobbies. Thank you.
Questions at this time.
All right, thank you for your time today.
Yes, thank you. Rest of your day.
And friends, thank you for your participation. You may now disconnect. Please stand by for the post-conference.